TopMedTalk.
This is TopMedTalk, the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. The EBPOM World Congress is taking place this year between the 7th and the 9th of July at the British Library in London. Check out ebpom.org now. Welcome to TopMedTalk. This is part one of a two-part piece. It's our annual digest of our coverage of anesthesiology, the annual general meeting of the American Society of Anesthesiologists. The TopMedTalk team attended the meeting, and in this piece, we're looking back at some of our coverage. Don't forget, all the podcasts we discuss in this piece are available in full for you to listen to. All you need to do is check out the show notes on this podcast for links to them. Coming up, anesthesiology economics, current trends and future directions, navigating governance in anesthesiology groups, clinical readiness, the Pain Medicine Coalition, insights from the ASA presidents, both past and present, artificial intelligence, data management, and insights on the future of anesthesia quality improvement. But to start with, we're looking at pediatric airway management advances. In this piece, Desiree Chappell and Andy Comsty discuss difficult airway management with Anna Garcia Marcinkiewicz. She describes key pediatric and neonatal airway challenges, often, of course, compounded by illness-related physiological difficulties. She discusses evolution from limited tools to pediatric proportion devices, and highlights and mentions a pediatric difficult intubation registry.
Yeah. So we have a collaborative, the Pediatric Difficult Intubation Registry. It's a wonderful collaborative started by amazing mentors over 10 years ago. And it has grown. We have 40 centers all over the world. And anytime that we encounter a difficult airway, we then log in demographic information, case data information, what was done to manage these airways. And then we learn from these experiences to then be able to set the next prospective studies and then figure out how to keep kids safe during airway management.
It's well worth a listen, and it is, of course, available for free to you in the TopMedTalk archive. Go check it out. Our next podcast features Mary Dale Peterson, Executive Vice President and Chief Operating Officer at Driscoll Children's Health System, serving as chair of the American Society of Anesthesiology's Workforce Summits, and a member of the ASA Charitable Foundation's Board of Directors, and Thomas Miller, Director of Analytics and Research Sciences at the Center Anesthesia Workforce Studies.
I just want to put a plug in for the Center for Anesthesia Workforce Studies. And so we have all this beautiful data and it's refreshed charts. It's refreshed every single month.
From the ASA community.
Yeah.
Okay.
And plus, if there's something missing, they can email us. We will either get it for them or find the right person.
And it's all archived on our website, hq.org, and you go to the cause area, CAWS, of the website, and we've got all of our enduring materials from our workforce summits, solution-driven, things that you can look at materials that give you ideas of what might work in your own location when you're struggling to not close rooms, or what do I do? How do I talk with a hospital? We've got even compensation data and what's happened there on various entities. And so it's very well done, and it's updated every single month.
They also direct you to the ASA's Center for Anesthesia Workforce Studies resources at asahq.org. That's asahq.org. Now, artificial intelligence is continuing to revolutionize healthcare. In this next piece, Understanding Anesthesia Information Management Systems, with Dr. David Kennedy, we heard how that revolution was continuing.
You could even see in the future maybe the AI making adjustments to the gas line.
Closed-loop system.
And kind of helping you with closed-loop systems. Absolutely.
We've talked a lot about that. And we always say that computers can do it better. They can pick up on nuances that the human eye and the brain cannot possibly pick up.
And there are concerns, right?
How are some of the AIMS platforms addressing that?
So the black box issue just says that when an AI system looks at a situation and makes a recommendation, sometimes it's not clear as to why it arrived at that recommendation. We as clinicians, we know kind of what our thought processes are, and we know what our education level is that leads us to that conclusion. We need to be able to understand what the AI was thinking to be able to say, this is what you need to do.
Dr. Kennedy describes AIMS, Anesthesia Information Management Systems. These are electric record systems used during anesthesia care to replace traditional handwritten cards. Digitized records, of course, enable analytics for quality improvement and targeted feedback, also supporting financial efficiency and reducing delays, cancellations, and unnecessary testing complications. The discussion highlights AI-driven real-time warnings, predictive analytics, and clinical decision support. Subject of AI emerged during our conversation with the ASA presidents. Every year, we like to have a conversation with the incoming and outgoing president of the American Society of Anesthesiologists. In this instance, Desiree Chappell and Mike Grocott interviewed the outgoing ASA president, Dr. Don Arnold, and the incoming president, Patrick Guillaume.
I think AI will be a game-changing force. So I did an interview once where they asked me, what do I think the future of AI will be? And I'm thinking that it must have been when they asked somebody, what do you think the future of electricity will be? I think it's difficult to anticipate what directions it's going to go, but I think we're very excited for it. But we would view it more not as just artificial intelligence, but maybe augmented intelligence. Maybe the AI helps bring in the massive data streams, which we're responsible for and need to analyze on a second-by-second basis, and helps us bring that into a readable form where we can create knowledge and information to help drive our real-time decisions.
It's a fascinating conversation, well worth checking out. Link in the show notes. Meanwhile, Andy Comsty and Kate Leslie spoke with Seema Narouz, chairman of the Centre for Pain Medicine at Western Reserve Hospital and chair of the Pain Committee for the ASA. The podcast is called Transforming Pain Medicine, an insight into the Pain Medicine Coalition.
We have to understand the whole picture of chronic pain, the psychosocial economics of pain. It's not just you need to remove the cause of the pain. You need to treat the consequences that this pain left behind. Depression, anxiety, isolation. So that's why I'm saying we are rebranding it. It's not just medicine to treat one aspect or an injection to block this nerve. No, this is one piece out of the whole picture. We need to treat the whole patient to make again the patient functioning and forgetting this bad experience with pain, not just removing the cause of pain. Removing the cause of pain is number one in the step, but you have to treat the consequences that happened from years and years of pain. So that's why it feels great that when you see the patient coming back with family members, I have my family back. I was able to go to this wedding, able to travel, attend the graduation of my grandson. This is priceless, seriously.
Totally.
Also at Anesthesiology 2025, clinical readiness and training affiliation in Army anesthesiology. Desiree Chappell speaks with Lieutenant Colonel Daniel P. Raboin. He's an Army anesthesiologist and pharmacist who serves as the Deputy Anesthesiology Consultant to the Army Surgeon General. Lieutenant Colonel Jordan Lane joins us as well. He's an Army anesthesiologist at Tripler Army Medical Center in Hawaii, alongside Colonel Michael S. Matowski. He's an Army anesthesiology consultant to the Surgeon General.
You were a credentialed anesthesiologist, but were you really ready to do the mission you'd be required to do?
So it's all about kind of standardizing how
Yeah.
you approach readiness for your entire group.
And I think that's one of the great things that Mike has done for our specialty since he's taken over as consultant. It started with his predecessor, Dave Ruffin, but Mike has really taken it and run with it. I can let Mike probably talk a little bit more.
So the thing with the Army is readiness to the Army is a consistent cycle of evaluation. Like every unit gets evaluated doing their deployment job and they're certified that they're ready to go. It's something that it's been proven that they're ready to do their job. In clinical medicine, when we talked to higher ups years ago, it was, how do we know the Army medicine's ready?
On the subject of preparedness, navigating governance in anesthesiology groups is a fascinating piece where you hear Mike Grocott with Sheena Scott, founder of Scott Healthcare Consulting, and Jason Greenberg, strategic advisor at Anesthesia Ventra Health.
One of the things I hear most often from physician leaders is that their biggest challenge is dealing with their partners. If they're not properly empowered, then they can't deal with those dissenters, and that can put the group at risk. The group is as strong as its weakest link. I think that has to be an important part of governance, that the leaders are empowered to deal with people who are unwilling to get along.
Very politely put. I would add a couple important points here. Strong bylaws that the group gets behind and that are vetted are incredibly important. If you don't have the framework in terms of the bylaws of the group, you can't expect that you've got a pathway for dealing with this. The other thing I would say are physicians are classically conflict avoidant. We're not necessarily trained to engage in conflict. That being said, the groups that don't hit up head on when we've got unhealthy detractors will see a significantly more downside in the end if they don't actually take advantage of their bylaws and the pathways they have to deal with it. The last thing I would say is have a great labor attorney on speed dial at any point. It's important to do the right thing, to take the health of the group as number one over any individual need. At the end of the day, avoiding conflict, not following your bylaws, not taking care of issues that are out there will lead to group demise.
The conversation highlights the challenges of democratic decision-making in larger groups and the need for emotional intelligence in leadership and methods to address detractors and conflicts. They also emphasize the importance of bylaws outside consultation and continued professional development through resources like the ASA's Advance Meeting. Also on TopMedTalk, anesthesiology economics, current trends and future directions. Desiree Chappell and Sol Aronson discuss the evolving economics of anesthesiology with their guests, Jonathan Gall, Professor of Anesthesiology at the Department of Anesthesiology, Perioperative Pain Medicine, Icahn School of Medicine at Mount Sinai, and Gordon Morwood, Anesthesiologist-in-Chief at Temple University Health System, Chair and Professor of Clinical Anesthesiology at Lewis Katz School of Medicine and Temple University. The conversation spans various models of payment. They delve into the nuances of navigating different payer systems, such as Medicare, Medicaid, private insurance, highlighting recent trends and challenges.
Better quality care is actually cheaper care. Like people talk about, we want to improve quality, but actually what you're saying is we want to stop paying for all these expensive complications.
Avoidable. But how do we declare our role in delivering that quality?
I think there's a number of different aspects to it, but it boils down to making sure that you have the right patients getting the right care at the right time. There are lots of patients still getting into our healthcare system, undergoing procedures because we pay fee for service. We pay for the process. So they undergo the process, but the outcomes aren't great. These frail patients whose risks are extraordinary, by anesthesiologists as gatekeepers, as part of, if you had
perioperative process,
if you had sort of like a tumor board approach to really high intensity invasive procedures, and you had surgeons, internists, anesthesiologists, nurses all sitting around the table and saying, okay, is this patient really who we're going to spend $50,000 on?
They also discuss the impact of the No Surprises Act and the ASA's ongoing advocacy efforts. The episode underscores the importance of proper economic strategies to ensure the sustainability and optimization of anesthesiology practices. Another podcast we'd like to highlight, which you'll find a link to in the show notes to this podcast, is called Insights on the Future of Anesthesia Quality Improvement with AQI. Desiree Chappell and Mike Grocott discuss the latest advancements and key topics in the field of anesthesiology, with special guests Sheila Barnett, Chair of the Department of Anesthesiology at Dartmouth Hitchcock Medical Center, and Patrick Guffey, Professor of Clinical Practice, Anesthesiology Pediatric at the University of Colorado Anschutz Medical Campus. The conversation centers around the Anesthesia Quality Institute, AQI, and its various initiatives, including the National Anesthesia Clinical Outcomes Registry. Have a listen.
And I think it's important for anesthesiologists to understand, too, this is our registry. It's going to be about us, what we want to do with it, how we can empower our specialty to get even better and bigger and really show our perioperative value even more. And I think that's really important. It's not an Epic. Epic is obviously, central to this. The data is going to be fantastic. They're great to work with, but it is still coming back into an anesthesia registry. And I think that, that hopefully our members will feel trust in that, the ability to question and ask and use us.
I was going to ask that. So if you're an ASA member or not an ASA member, can you put in a request to address a particular question, that kind of thing?
Yeah, I think once we have this spun up, there's definitely going to be that opportunity. Get in a situation where participants may have a quicker path to that information for privilege of participation, but we still have a strong committee structure.
To hear more of that conversation, or indeed any of the pieces we've discussed here, do check out the links in the show notes to this podcast. Now, another important conversation that we had during last year's meeting, new guidelines for anesthesiology in older adults. Andy Compsty and Kate Leslie welcome their guests, Stacey G. Diner, an anesthesiologist, professor and vice chair for research at Dartmouth Hitchcock Medical Center, and Mark D. Newman, anesthesiologist, and Horatio C. Wood, professor of anesthesiology at the Perelman School of Medicine at the University of Pennsylvania. We discuss the new ASA guidelines for older adults. The episode delves into the development, significant recommendations, and implementation of these guidelines, emphasizing the importance of pre-operative evaluation and the choice of anesthesia technique.
We learned that there's a real desire on the part of patients to be involved in their own choices. Having surgery for older adults can be a moment where there's a real loss of control or feeling of vulnerability. Engaging people in decisions about their own care is a way of giving back some control, some agency. And in this research that we're doing through My Anesthesia Choice, which is our effort to implement the regained findings into practice through shared decision-making, it's been wonderful to see patients and clinicians engaging. And what we've learned is that through very simple things, just showing that there's a choice and offering information, you can engage folks as partners in their own care. So I think that that's one thing that I hope is on the horizon for our field as a future, to really bring back some of the physicianship and humanity into these conversations, to really give folks an ability to be part of their own care.
Mark and Stacey also highlight ongoing research in the future of perioperative care for older adults. It's an important conversation, and it underscores the role of shared decision-making and proactive health measures in improving surgical outcomes. And finally, for now, we'll have a look at nitrous oxide as a treatment for severe depression. Andy Compsty and Kate Leslie at Anesthesiology 2025 in, of course, San Antonio in Texas, interviewing Peter Nagel, professor of anesthesiology at the University of Chicago, about his groundbreaking trial on the use of nitrous oxide as a treatment for severe depression.
There may be two elements to understanding sort of the neurobiology. One is what mediates the immediate onset, right? Why does it's like flipping a switch, right? And what is the mechanism behind this? And the second is, why is it persistent? Because nitrous, we know, leaves the body in minutes and at most hours, right? So why would this stay the antidepressant effect for weeks? So something in the brain must change. And it seems like it reminds me more of, like, we think about cardiac, like an arrhythmia, you kind of like, defibrillate or cardiovert, right? And then you have a persistent effect. So I think that analogy is like you need something that flips the switch and then maintains it. But I think we're very early in trying to understand kind of like what's behind.
It's a fascinating piece, and it highlights the need for novel treatments for treatment-resistant depression and the importance of collaborative research in advancing medical knowledge. This was part one of a two-part piece. In part two, we'll be looking at some more of our coverage from Anesthesiology 2025.
TopMedTalk.
TopMedTalk is the broadcasting arm of EBPOM, Evidence Based Perioperative Medicine. Join clinicians from around the world at EBPOM World Congress 2026 between the 7th and the 9th of July at the British Library in London. 3 days of evidence-based perioperative medicine, global insights and expert debate, featuring speakers including Michael Marmot and Ken Rockwood. Go now to ebpom.org. That's ebpom.org.